Yeah, we're just waiting for him to, no? Go for it? All right. No.
Welcome to the visitors and to everyone. Every Friday we have a cardiology education conference, typically put on by the attending physicians, various topics, EKG, board review questions, cardiology guidelines, and once a month the residents who have been on service present a topic or a patient-related topic, and today is that day or that Friday of the month. So these guys are going to take over. They work very hard.
Can you guys hear us okay? All right. So my name is Lynn. I'm one of the family med second year resident here. I'm with Dr. Soni, and today's topic is on aortic stenosis. Okay. All right. So aortic stenosis is defined as narrowing of the aortic valve with flow greater than or equal to 2 meters per second. With aortic stenosis, the prevalence actually increases with age, and the common group that you would see that in is 65 through 85 years of age. And you have as high as prevalence of 4% in those that are 85 and older. There are certain risk factors associated with it, such as rheumatic valve disease. In fact, that's one of the most common cause worldwide, whereas calcific disease is the most common cause for aortic stenosis in Northern America and Europe. There are also metabolic disorders associated with this, such as SLE, alkaptonuria, Fabry disease. If you have disorders that affect calcium metabolism, such as renal disease or Paget's disease, will also increase your risk of aortic stenosis. Okay, I just want to draw everyone's attention to the easy bruising and epistaxis as a symptom of AS. Does anyone know the syndrome that's related to this by any chance? Hyde syndrome, yes. So in our blood, we have something called von Willebrand factor that's circulating in its active and inactive state. Usually in its inactive state, it's unraveled. But when it senses any sort of endothelial stress, you have this unraveling that activates it. And it senses the shear stress from AS, aortic stenosis, as an endothelial stressor. So all of it, as it passes through the aortic valve, gets activated. And to compensate for this overactivation, there's a metalloproteinase protein called ADAM-ST13 that catabolizes the von Willebrand factor. So that effectively causes von Willebrand deficiency. And with AS, you have increased risk of angiodysplasia, AVM malformation with age, and that inherently causes your increased risk of bleeding. Okay. So what are signs and symptoms that we look for in someone with AS? Pulvis, parvis, et tardus. So if we break that down, that means weak and delayed pulse. There's a very distinct crescendo, decrescendo systolic murmur that can be heard in the right intercostal space. It radiates to your carotids. It could be louder with squatting, softer with Valsalva, and a completely silent or absent S2 is indicative of pretty severe AS. Sometimes you could feel a thrill felt at the base of the heart and the sternal notches. You can feel it more pronounced as you have the patient lean forward. Sometimes you'll hear an S4 heart sound because with time and prolonged AS, you have left ventricular hypertrophy, which decreases the compliance of the heart, and hence the S4 heart sound. So there are an array of symptoms, but the three that I want to draw more close attention to, and I'll mention why the importance of it in later slides, is the angina symptom, syncope, and shortness of breath. Those are the three very important symptoms that we'll talk about more later. But you can also have dizziness, fatigue, you can feel palpitation, and in children with AS, you'll see that they have failure to thrive. They don't put on weight as well. They look a little bit cachectic. Okay, So to go into a little bit more about the murmur that you'll hear, the systolic crescendo decrescendo. So as blood is ejecting out of that stenotic valve, it becomes very turbulent, and you'll hear this sound. There's this phenomenon called Galliverian phenomenon, which shows that the aortic sound doesn't just limit to the right sternal border. It could be actually all the way towards the apex of the heart. And as you auscultate your way down towards the base of the heart, sometimes there's a change in quality from that systolic crescendo decrescendo to like a musical quality. So I'll play you a little bit of that clip. I've never actually heard it in person, but let's see if it works. Excellent. All right. So how do we diagnose AS? The gold standard, the study that we usually start with, non-invasive, easy to do, is the echo. There are certain parameters that you'd be looking for in an echo. You look at the diameter of the valve itself. You look at the flow that comes out of it. You'll look at the gradient flow between the aortic valve and the ventricle itself. And that kind of helps you quantify the severity of AS. You can do an exercise stress test, but it's contraindicated in anyone with symptomatic AS. You don't want to do that. Someone with asymptomatic AS, you want to be able to test their functional capacity, because there are a lot of those out there that may have masked symptomatic AS just because with age, AS prevalence increases, their activity decreases, and so there's really no trigger there that shows or trigger that incites these symptoms. You can do a CT imaging of the chest, and you usually do the CT when you have discordant echo findings. Specifically, you would look for a population of patient who have echo findings that show low gradient, low flow, but normal ejection fraction. And what you look for there is the aortic valve calcification score. And in women, if it's greater than 1,200 or men greater than 2,000, it's indicative of pretty severe like hemodynamic unstable AS. Cardiac cath is the least used method of diagnosis because it's more invasive. And as you thread the catheter through the aortic valve, you increase the risk of stroke. So you usually don't go to that straight off. The reason you would even consider that would be if you have discrepancy between your echo findings and clinical signs, and you would use a cardiac cath to assess AS that way. So this is an echocardiogram of AS. Oop. Something happened to our clip there. Oh. All right, so you can see kind of the decreased leaflet motion of the aortic valve. And then in just a quick second, I want to point out something called aliasing, which is that kind of mosaic pattern, a jet velocity going through the valve that suggests turbulence. Yeah, you can see the kind of dome shape of the aortic valve earlier. All right, disease progression. So this is kind of hard to really tackle. There's usually a prolonged period of asymptomatic for AS, and then once symptom progresses, pretty poor indication. However, the disease progression is different in everyone. It's really hard to guess. You could do serial monitoring with repeat echoes depending on their severity of AS. If they're mild, moderate, severe, you would do it less frequently or more frequently, but none of those things really tell you how rapidly it will progress to advanced stage. But there are certain risk factors that indicate faster progression. Old age, male gender, high cholesterol, diabetes, smoking, metabolic syndrome. And of course, if you can imagine, if you have a unicuspid valve, that will become calcified and stenotic much more quickly than a bicuspid. And then lastly, a tricuspid valve. So this is kind of a nice diagram of what a healthy aortic valve would look like and a stenotic valve. And I think one of the best analogy anyone ever uses to describe like hemodynamics of AS is with the hose. As an opening narrows more and more, you have that increased velocity that goes through. And that helps us kind of define the severity and grade of AS too. You can see the most severe, the opening is less than 1 centimeter square, whereas normal is greater than 3 centimeters square. Okay, so progression of severe asymptomatic AS. So there was a study, actually there were 5 studies done that showed that those with AS with Vmax of greater than 4 meters per second tend to have rapid decline. Okay, and then going back to that 3 core symptoms that I mentioned earlier, the angina, the syncope, and failure. The onset of these symptoms kind of gives us an idea of the progression of the disease and their survivability. So going from the least severe to the most severe, if you start with angina, it's predicted that those people will live up to like 5 years. If you have syncope, up to 3 years, and if you have heart failure symptoms like shortness of breath, is 2 years. So it happens rapidly after the onset of symptoms. Okay, so some pathophysiology behind AS. Why does someone have angina with AS? Well, if you can imagine, stenotic valve, low blood flow, less perfusion of the coronary arteries. Poor cardiac output leads to poor perfusion of the brain, so you have syncope. Shortness of breath is when you have longstanding AS and you have this compensatory mechanism where you develop hypertrophy in the ventricles, decreasing the compliance, causing diastolic dysfunction and eventually pulmonary congestion. And just to remind you, that's the worst symptom. Okay, so this is kind of a busy slide, but if you can just pay attention to the red, the green, and the blue, that's how you lump it up. In the red, you'll see that these are all severe symptomatic AS. And severe, for the most part, is defined by less than 1 centimeter, less than 4 centimeters per second flow, and less than 40 or greater than 40 millimeters of mercury for the gradient. In the green, you'll have your asymptomatic severe AS, and then in the blue, you have your at-risk or mild. So in D2, these are your special subclass of people with severe symptomatic AS, where they have low ejection fraction. And in those, to grade them accurately, you have to do a debunamine stress echo. And then for class D3, again, we mentioned that these are the special ones with low gradient, low flow, but normal ejection fraction. These are the types of patient that you need to do the CT chest to do the aortic valve calcification score on. Okay, so what is the treatment and management for AS? Truly, there's no medical management for it. To definitively treat, you need to replace the valve. But up until that point, when people qualify for surgery or a valve replacement, there are things that you can do to manage coexisting comorbidities, and to also control the symptoms. So with hypertension, there's kind of like a narrow window in which you want to control them. You don't want to overly control, but you don't want to let it go uncontrolled as well. You want afterload reduction, but you want to have that narrow range where you can optimize your level of perfusion and decrease the level of strain against the left ventricle and against the stenotic valve. And for angina, you can give them beta blockers, calcium channel blockers, but you generally want to avoid nitrates because of the vasodilation causes decreased perfusion. Statins haven't really been shown to change anything about the progression of the disease at all, but with coronary artery disease being a coexisting comorbidity of AS, you can at least reduce ischemic events that way. Heart failure is the same thing, very delicate hemodynamic balance there. You want to diurese them, but with caution because AS is a preload dependent state. If you overly diurese, you continue to worsen your cardiac output. And I mentioned before the serial echoes. If it's mild, you want to do an echo every 3 to 5 years. If it's moderate, every 1 to 2 years, but if it's severe, every 6 to 12 months. Okay, so once you decide that someone has very severe AS and you know medical management isn't going to solve the problem, how do you decide when and if to go under valve replacement? So you can break it down to those that are symptomatic and those that are asymptomatic. We'll start for the symptomatic individuals. So those you start with the velocity, and if it's greater than 4 meters per second, they qualify for replacement. If it's less than, you have to look at the ejection fraction. So if the ejection fraction is less than 50, that brings us back to the class D2 that we mentioned before. You have to do the W-mean echo stress test. And if they fulfill all the criteria for that, and then you advance further to replacement. If not, you can do periodic monitoring. And then that's our special class D3, right next to it, where you have low flow, low gradient, normal ejection fraction. You would have to calculate the stroke volume index and do a CT to do the aortic valve calcification. And if they meet those criteria, then you move on to replacement. For those that are asymptomatic, similar, you have to look at the Vmax. If greater than 5 meters per second, low risk of surgery, you advance to replacement. If less, then you do periodic monitoring. And in between, again, looking at ejection fraction. Those that are asymptomatic have to go through the exercise stress test to reveal the mask symptomatic AS individual. And if you find that it's a negative stress test, that you truly are asymptomatic, you have to look at how rapidly they're progressing with the disease. Do they have those risk factors that we mentioned before? Male, gender, older age, cholesterol, diabetes, metabolic syndrome, are they a smoker? And assess them that way. And once you determine that they do qualify for a replacement, we have to go right here, one of 2 ways. You either go for the TAVR, the transaortic valve replacement, or you go for surgical valve replacement. And in order to do that, you have to assess the risk. Generally speaking, with the current guidelines, if you're low surgical risk, then you have the surgical valve replacement. If you're prohibitive surgical risk, then they'll consider TAVR. So the first surgical aortic valve replacement was done in the 1960s, but they were more successful for those that are fairly young with less comorbidities. The end result of that is just much better in that specific group. So that's why TAVR was created, and that was done in 2002. But there are more and more research out there that is looking at the low surgical risk, and they're suggesting that TAVR may be still a good option for these people. And keep in mind, this graph is from 2014, so a lot has been done since then. All right, so you have symptoms, that means you have to intervene. As you see on the graph, those that underwent surgical valve replacement did much better than those that were conservatively managed. So there's different things that you can do for intervention, balloon valvuloplasty, aortic valve repair, but those are just temporizing measures. What you're really ultimately need to do is either replace it or do the TAVR. Okay, so narrowing down to those 2, who qualifies for TAVR, who qualifies for surgical valve replacement? You have a lot of different risk assessment tools for surgical risk. The most common one is by the Society of Thoracic Surgeon, predictive risk mortality. known as the STS-PROM. You also have to look at their frailty index. That's really important, and their other comorbidities, like any organ dysfunction, whether it's cardiac or non-cardiac, to really be able to identify their risk level. Now there's this newer risk assessment tool called STS-ACC in the hospital. That's been shown to be more accurate, but it was only studied in TAVR patients. There are certain poor outcome comorbidities to think about. So in the cardiac, you think of severe pulmonary hypertension, you think of those that have severe mitral regurg, those that have coronary artery disease. Those patients tend to have poor outcomes. In the non-cardiac comorbidities, you think of things like chronic renal disease, COPD, diabetes, those kind of things, and poor frailty would increase your poor outcome. Okay, so this kind of simplifies it, some of the things we've talked about before. All right, so Dr. Soni is going to talk a little bit more about some of the studies in TAVR.
Hi guys, so I'm going to talk about the transcatheter aortic valve replacement. So first TAVR was done in 2002, and since then there have been more than 200,000 TAVRs that have been performed. There are two types of valves available. One is a balloon expanding bovine valve, and the other one is a self-expanding porcine valve. In the process of selecting a patient for a TAVR, there's a multidisciplinary team that's required. It's not as simple as accessing the artery and placing the valve. It is not for all patients. It's not for patients that have symptoms secondary to non-cardiac issues, and their symptoms are not related to the aortic stenosis. And it's not for patients who have less than 12 months mortality. And this is a brief video on the procedure, what it looks like. So that's the catheter, and this is where the valve is. And they induced ventricular tachycardia to decrease the cardiac output while the valve is being deployed, and that was the valve. This is a stenotic valve. And this is the balloon valvoplasty that's done prior to the placement of the valve to make room for the valve. And this is the valve replacement device itself. The valve is deployed. All right, and it's functional as it's once it's deployed, it's functioning right away. You can see the valve open and close, and that's what the device looks like. All right. So considerations before performing a TAVR. Of course, you have to have a transthoracic echocardiography to assess the degree of aortic stenosis. This also is followed by a CT chest, which will assess the size of the aortic annulus to see what size of valve they require, and the coronary sinus dimensions and the height of the left main sinus. Similarly, following this, they also require a CT abdomen pelvis to assess the tortuosity of the femoral arteries to see if they can do a transfemoral or transapical approach. And also see the calcium burden on these patients. Coronary angiography is performed prior to the TAVRs because about 40 to 70% of the patients undergoing or TAVR or having aortic stenosis have some degree of coronary artery disease and end up requiring intervention. So doing an intervention prior to the TAVR deployment is easier because once the valve is deployed, it may make PCI a little bit more challenging. Okay. This picture kind of illustrates the amount of work that goes into selecting a patient for TAVR and the amount of follow-up that's required once the patient undergoes TAVR. From the primary care provider, referred to a cardiologist, and their patient is followed by a valve expert, cardiovascular imaging expert, CT surgeons, anesthesiologist, and post-care valve clinic care coordinators. They also require a significant amount of imaging, as I mentioned before, repeat follow-up echocardiography after the valve is placed. And following which they require annual follow-up as well. Okay, current FDA-approved valves, as I mentioned, the Edwards Sapien 3 is the balloon expanding valve that we actually use in our facility over here, and the core valve, Evolut R, is a self-expanding TAVR valve. So major risks of TAVR stroke in partner trial 1A, it showed twice the rate of neurological events compared to surgical intervention in the first year. However, since then, partner 2 and partner 3 have come out and has showed actually decreased or about the same risk of stroke with TAVR. And initially, it was attributed to the refinement of the procedure and the device itself. Paravalvular leakage, that was a major problem with the transaortic with the TAVRs because the degree of paravalvular leakage is associated with increased mortality. Patients having moderate to severe paravalvular leakage have a higher mortality in the next 5 years compared to patients who had mild or trace. Conduction abnormalities and pacemaker requirements. In some cases, patients may require a pacemaker because post-procedurally, because they may develop AV blockade. And also, this was seen more in the self-expanding valve than in the balloon expandable valve, and in male patients or with patients who had a pre-existing bundle branch block. Okay, so this was the partner 1 trial, the partner 1B that was published in actually 2010. And it took about 358 patients using the first generation Edwards Sapien valve. And their primary endpoint was comparing TAVR to standard medical therapy, which was in patients that surgery was not an option. They had prohibitive comorbidities. The key thing to note here is the TAVR did showed significantly decreased death from cardiovascular or death for any cause. And in standard therapy group, they also received, about 83% of the patients received balloon valvuloplasty, which did not alter or change the course of their condition. And this was followed by this is the partner A group, which showed compared transcatheter surgical aortic versus surgical aortic valve replacement in high-risk patients. And this had about 699 patients. They were randomly assigned to TAVR versus SAVR. And their hypothesis was that TAVR is non-inferior to surgical option. And the key thing to note here is that more patients had improvement in their symptoms at 30 days compared to the surgical group. And over the course of 1 year, there was no significant difference compared to the TAVR versus SAVR. This was most likely because of the fact that they underwent a sternotomy, and in the next 30 days, they had a prolonged recovery period. The study also showed that death from any for cardiac any cause was higher in the surgical replacement group compared to the TAVR group at 30 days. Stroke or ischemic events were more in the TAVR group at 1 year mark, and vascular complications were also more with the TAVR group. However, major bleeding was more in the surgical group of the patients. The next study here was the Partner 2 trial that was published in 2016, involved about 2,032 patients, and they were randomly assigned to surgical versus TAVR group. And in this case, the primary endpoint was death from any cause or disabling stroke at 2 years. They followed the patient for 2 years, and their primary hypothesis was that TAVR is non-inferior to surgical replacement, which they did achieve. The other thing to note here is that the TAVR group did have more paravalvular valve leakage, and this again was attributed to initially using the second generation device, and they were these valve replacements were performed in areas or hospitals that didn't have prior experience with the SAPIEN system. And in this study, they used the second generation SAPIEN XT system. These were done in patients that had intermediate surgical risk, and similar results were shown with the SURTABI trial, which used the self-expanding core valve device. And this is the Partner 3 trial that compared surgery versus TAVR in low-risk patients, and which demonstrated their primary endpoint was death, stroke, or rehospitalization, and they also added that TAVR is non-inferior but also superior to surgery, and which was achieved in this study. It showed that TAVR, when performed by the transfemoral approach with the SAPIEN 3 system, was superior to surgery. TAVR was associated with lower risk of new onset atrial fibrillation at 30 days when compared to surgical valve replacement, a shorter index of hospitalization, faster improvement in their NYHA class, their 6-minute walk test, and the KCCQ overall score. And this slide is the current ACC guidelines in regards to when to choose TAVR versus SAVR. And the key thing to notice here is that it's more favored for older patients for TAVR versus surgery for younger patients. And the rationale is there haven't been studies accounting for how durable these valves are. However, there are the Partner trial investigators are following the patients to see the durability of these valves, but also there's also valve-in-valve replacement that can be performed in these patients. So these are due to change. This was the recovery trial that was published in November 2019. It was a small Korean study that showed early surgery versus conservative care in patients with severe asymptomatic aortic stenosis. They defined severe aortic stenosis with a Vmax of 4.5 meters per second, and it had some limitations. It was a non-blinded study, and it was questionable how asymptomatic the patients were. Not everybody underwent a stress test to assess their asymptomatic status. And the reason that is important is because as the disease progresses, patients may minimize their own function and say that they're asymptomatic when they're truly not. And the study was in largely Asian population and younger population. The partner trial had their populations in the mid 80s, if I recall correctly, and this study had their populations was in their 60s. The trial looked at surgery, not TAVR. So this slide kind of summarizes where we are now. We started in 1961 with the first surgical valve replacement, followed by the first human TAVI done in 2002. Since then, Partner A, Partner B, the core valve trial, Partner 2, Surtavi, have been done. And along the way, FDA has approved these devices for up to intermediate risk patients. And the Partner 3 trial and the recovery trial got recently published, and early TAVR trial, which is looking at performing TAVRs in patients asymptomatic severe aortic stenosis, and Evolve trial, which is looking at cardiac biomarkers towards assessing patients for aortic valve replacement. Those are upcoming, and the guidelines will definitely change in regards to who is a candidate for aortic valve. The one thing that we do know is that patients with aortic valve who have aortic valve stenosis, who have severe stenosis, do have a considerable mortality benefit that's associated with valve replacement. And this is a surgical problem and requires some kind of intervention. All right, thank you.
Questions?
What are the recommendations you're reading about TAVR, about anticoagulation and TAVR? Did you come across that?
I did. So initially they did 6 months of dual antiplatelet, and now they are also looking into doing novel agents for 6 months and then aspirin only.
It depends on who you want to believe. Yeah, it's a controversial. There's a controversial topic. I was curious what you thought. Traditionally, it's been a dual antiplatelet for 3 to 6 months, but the efficacy of that has been challenged, and it's felt that a single platelet agent may be fine. But there are some people at the other end of the spectrum that will say that full anticoagulation should possibly be done for 3 to 6 months. The Mayo Clinic pushes, I think, used to push that. I don't know if it's still doing. So it's really a wide open. I was curious what you thought, but it seems like the last stuff that I read from September, single antiplatelet may be as good as dual antiplatelet.
Yeah, I was just looking that up actually while they were talking to see the Europeans said antiplatelet therapy. But there is a recommendation and low bleeding risk to give folks a Cantabs for 3 to 6 months plus antiplatelet therapy. Sometimes antiplatelet therapy indefinitely, but they're aspirin.
My nurse practitioner had a patient this morning who had a TAVR 6 months ago, who was told she can't take aspirin She has a prior gastric bypass surgery and has been on Plavix. She's very unhappy on Plavix because it's a easy bruisability. And when I was reading my NP's note, proof in the note this morning, she had stopped both. And I kind of changed her note, we'll reassess. And then she spoke to two of our interventionalists, and both said it's okay to be all antiplatelet therapy. But then I talked to our youngest who just came out of training, and he said most people are doing single antiplatelet therapy, but in situations where they just can't tolerate any, maybe not. But no one knows.
I think you kind of mentioned in passing, but to our residents and guests, if you have something bicuspid aortic valve, remember the aortotomy is a connective tissue disease. And you would never, if you hear a click and they have a bicuspid aortic valve, be sure you check the aorta. Because they may need their valve replaced at only moderate severity if they have an aortic aneurysm. So it's bicuspid aortic valve is very important to remember that association. So any other questions? Hey guys, very good job. Thanks to our guests for coming. Have a safe trip home.